Welcome, everyone. On behalf of Mapol Inc., we are pleased to present the webinar entitled Developing More Inclusive Benefits in 2021, Why Fertility Benefits Matter, sponsored by Conceivable Dreams, a grassroots organization that advocates for current and future families by building awareness and empowering choices to address fertility and reproductive health issues. This event is part of Mapol Incorporated's ongoing webinar series for education in healthcare policy and pharmaceutical product coverage in Canada. Those of you who have registered in the past will be familiar with the format of these events. Mapol is a consulting firm that works with all stakeholders in the private payer market for issues pertaining to pharmaceuticals within plan sponsor health benefits plans. Today, we will have two facilitators, one being myself, Leslie Wong, joining from downtown Toronto, and the other being Johnny Ma, president of Mapol Inc., who will be facilitating from Brampton, Ontario. At this time, we would like to welcome our attendees who are representing almost all provinces across Canada. These webinars are offered by invitation only and are held for private viewing. Thank you very much for taking the time to attend this webinar. To get started, you will see the agenda on the screen. Today, we will have two guest presenters, Dr. Kimberly Lui and Yafa Sakkejha. Also, as indicated on the agenda slide, we will have a question and answer session with all speakers following the presentations. I will now pass it over to Johnny to facilitate some polling questions before we begin the presentations. Welcome, Johnny.
Thank you, Leslie. At this time, we usually allow our attendees to get familiar with the polling process by asking the following question. Which stakeholder group do you represent? A, insurance company. B, benefits consultant or broker. C, employer. D, pharmacy benefits manager. E, third-party administrator or TPA. F, other. As you can see, the majority of our audience today is in B, benefits consultant or broker. So thank you very much for that. Before we go to our presentation, we have one more polling question for you. And that's polling question number 2. Are fertility drugs currently covered under your benefits plan? A, yes, covered in all plans. B, yes, covered in most plans. C, yes, covered in some plans. D, no, fertility drugs are not covered. Or E, don't know. Please make your selection, then press submit. Okay, so the results are up, and I see the majority are in C, yes, covered in some plans, followed next by in most plans or not at all. So quite a wide range, and some do not know. So it's great feedback. So thank you for that. At this time, I'll pass it back over to Leslie.
Thank you for participating in our polling questions. Before we introduce our first speaker, we wanted to mention that this webinar is part of the Fertility Benefits Matter campaign. The campaign is anchored in new research that finds most Canadian employers do not provide any fertility benefits, and those that do provide an average lifetime reimbursement of $3,250. As you will hear today, this level of coverage is not sufficient to help people who need assistance creating a family. To learn more following the webinar, please visit fertilitybenefits.ca. At this time, I would like to introduce you to our first speaker, Dr. Kimberly Lui. Dr. Kimberly Lui is the medical director at Mount Sinai Fertility in Toronto, Ontario. She completed her residency training at the University of Alberta in OBGYN and a fellowship at REI at the University of Toronto. Dr. Lui also holds a Master's of Studies in Law. Dr. Lui is currently an associate professor at the University of Toronto, Department of Obstetrics and Gynecology, and the former program director for the U of T Gynecologic Reproductive Endocrinology and Infertility Fellowship Program. She is the author of numerous research publications and several national guidelines for fertility and ART practice in Canada. Welcome, Dr. Lui.
Thank you so much, Leslie and Johnny, and thank you very much to Mapol and to Conceivable Dreams for inviting me to speak and for organizing this webinar. I wanted to first set the landscape, particularly and talk about fertility treatments, but also address who are the people that actually need fertility treatments. And I start with this slide because I think most of us think about infertility and fertility treatments being connected. Some people may have also heard how infertility is quite common. And in fact, the common statistic that we hear is that 1 in 6 couples are affected by infertility. And that is definitely the case, and why fertility treatments are important in that population. But that's actually only one part of the population that accesses fertility treatments. There are a number of other people that access fertility treatments for a variety of other reasons. And I've listed a couple of these here just to demonstrate how much this reaches across the population. So in our clinics, we see single people who are wanting to start a family. We see members of the LGBTQ community who need assistance in starting their family. There's a significant population of patients that do fertility preservation as well, who require fertility treatment, both at the time that they're preserving their fertility and then in the future as well, when they actually want to use their sperm or eggs for conceiving a pregnancy in the future. This can affect patients who are undergoing medical treatment, such as cancer treatment, chemotherapy, or radiation, that we know can affect their fertility in the future. And so they want to preserve their current fertility before they embark on that medical and often life-saving treatment. This also can be for transgender patients. Often they do fertility preservation prior to the process of transitioning, or sometimes in the process of transitioning. And patients also, and particularly women or people who have ovaries and eggs, want to preserve fertility against age, because we know that that's a significant factor for fertility. So someone who's not quite ready to have a pregnancy at this point may want to think about preserving fertility, because they know that their fertility may decline over time at the point when they're actually ready to have their family. Other populations that access fertility treatment would be couples that have had recurrent pregnancy loss or who carry genetic conditions. And there's now new technology that can help prevent pregnancy losses or help reduce the chance of transmitting genetic conditions. And so even though those couples themselves may not have actually had trouble getting pregnant, they use this technology to help increase the chances of a healthy pregnancy in the future. So I wanted to also set the stage as to why this is coming up more. People ask me all the time, is infertility more common now? Why is it that we talk about it more? I think it's a combination of a few factors. We do see really a societal difference in pregnancy and fertility, even if we look over the last 100 years, definitely, and even over sort of the last 50 years, we sort of see some of those trends. So this is Canadian data, and it really looks at the fertility rate. And you do see, I know the slide's pretty small and it ends in 2011 and it starts in 1926. You see that over that time period, the total fertility rate, which is the number of children that a woman would have over her lifespan, has declined significantly from at its peak being close to about 4 down to now, which is at about 1.5. So that's a significant trend that we see across the world and definitely reflected in Canada as well. Other statistical changes that we see, or societal changes that we see, the age in which women are having their first child is also delayed. So they're waiting to have their first child for, again, a number of societal reasons related to education and jobs and just societal differences as to when people are planning their pregnancies and also how many kids that they're having. So back in 1959, the average age for somebody to have their first pregnancy was 23, and that's increased now by about 6 years to 29. And on the right, you can actually see that the overall distribution has changed as well. So in the gray boxes, that's, again, 1959 data, you can see that the bulk of pregnancies are actually happening under the age of 25. And even in that time period, if you then look at 2019, over that time, it's completely shifted in that the bulk of pregnancies now are happening in that 25 to 35 age range. So over that time span, we've seen a definitely difference in when people are having their pregnancies. And we all often know, I think, that age is a significant factor, more so for women than for men, but is a significant factor for fertility. And I think this graph really starkly demonstrates why that is. So the chance of pregnancy, which is the line in purple, as you can see, declines significantly. And again, I know the numbers are a bit small, but you really start to see that decline even in around the mid-30s. And the numbers become quite low if you look at over the age of 40. And at the same time, that dotted line, which you see increasing over that time, is the chance of miscarriage. So not only does it become harder to get pregnant, but at the same time, the chances of miscarriages are increasing as well, and they're both age-related. And overall, that results in a lower overall chance of having a healthy live birth as women get older. So I'm going to just talk a little bit as an overview about the breadth of fertility treatments that are available. So this can range from anything from fertility medications, which can be used for a number of indications to help people for sometimes hormonal issues or to help them ovulate. They're also often used in conjunction with other treatments that we offer as well. So treatments such as intrauterine insemination, which is a procedure where we put sperm into the uterus to help increase the chances of sperm and egg meeting and fertilization and subsequent pregnancy. IVF, which is a procedure in which the sperm and egg are actually in the lab, fertilized and developed into an embryo, which is subsequently transferred into the uterus. And then additional technologies that, again, sometimes used in conjunction for different indications. So genetic testing can now be performed on embryos, and that can be a way to reduce the risk of having genetically abnormal pregnancies, and sometimes reduce the risk of miscarriage, and can sometimes reduce the risk of transmitting a genetic condition that may run in a family. Additional treatment options include surrogacy, so in situations where somebody is unable to or can't carry a pregnancy, gamete donation, so egg and sperm donation, again, different indications as to why either that a person doesn't themselves or within their partnership have eggs or sperm or requires them because of, in some cases, a medical reason. And then as well, we also now can freeze and have for many, many years now frozen embryos and frozen eggs and sperm. And so in conjunction with preserving fertility for some people and also as a way to enhance the success of treatment options as well, allowing us to freeze excess embryos that can be used in the future, that's another technology that's also available to help increase the chances of pregnancy. So these are just an idea of the breadth of the treatment options that are available, and patients, depending on their situation, depending on the cause of either infertility or the reasons that they're seeking fertility treatment, may need to have any number of these, and in some cases they may have access to multiple of these treatment options over the course of their journey and to be successful in pregnancy. And just to know that fertility treatment costs often exceed what's available for government funding. And there's definitely a mishmash across the country as when you look at different provinces as to what's available for government funding. So in most provinces, the consultation process of either seeking a consultation for infertility or people that are seeking consultation around fertility preservation or family building, that consultation is covered, and a lot of the initial investigations are covered by provincial health plans. Treatment, however, coverage varies quite a bit across the provinces, ranging from Ontario, in which intrauterine insemination or IUI is partially covered, and IVF, infertility preservation, is covered for one cycle. In PEI, there's some financial support for medications and procedures with a limit of at 3 years of 5 to 10,000. Quebec also has some coverage for IUI in one cycle of IVF. Manitoba offers coverage in the form of a tax credit, and New Brunswick in the form of a grant, again, both to a specific limit. So there is some partial coverage across many provinces for treatments. And medications are part of that, again, in some provinces, but not in others. So as an example, I practice in Ontario, and although treatments are partially covered, medications are not at all. And so patients are often dependent on their individual insurance plans for coverage of medications. And Mapol actually recently did, and I'm sharing some information from a survey that they did, looking at benefits plans across Canada. I believe it was about 80 plans that were reviewed, small, large, medium companies across all the provinces, and did find that many employers did not provide fertility benefits. And the ones that they did often covered drugs, not necessarily treatment costs, with an average amount of coverage to be about a little over $3,000. And in the next couple of minutes, I wanted to share some common patient journeys that we see, and what you'll see is that this often is not enough coverage, in many cases even for one treatment cycle, and in many cases patients actually need to have multiple treatment cycles to be successful. So I'm going to start with one journey, and I'll go through a few, and these are very typical patients that I see in my practice. The first is Sophia. She's 36. She's single. She wants to know her fertility options. She wants to be a parent, and she recognizes that at age 36, she's being told that her fertility could be declining. She'd always imagined that she would have a child by this point, and she has thought about getting pregnant on her own, as she's not currently in a relationship, but she's not sure if she's ready. She's also heard about freezing her eggs, and she wants to know a little bit more about this. And so in addition to the consultation process in which we would talk about the different options and talk to her about what the success of those options are, we often have to have a discussion about what the costs related to these treatments are as well, again, because many of these things are not covered. And so egg freezing is not covered in Ontario where I practice, and because it's actually not considered covered for fertility preservation unless somebody actually has a medical need, and that's defined by somebody who's undergoing, let's say, cancer treatment. So if she did want to freeze her eggs, she would be paying for that procedure, and an average cost across the country would be somewhere between about $6,000 to $7,000 for that procedure. Medication costs would be on top of that, and that commonly can be between about $4,500 to $6,000 for medications for that cycle. And then she would actually also be storing those eggs, as it sounds like if she's not ready to use those now, and that cost is usually about $500 per year. The other option in this situation would be to actually conceive currently, and if she doesn't have a partner, to conceive with donor sperm. And we would often talk about what that option is and what the chances of success were. There's a cost in that case of the donor sperm itself. There's a cost of the IUI procedure, and again, that cost is a bit more variable across the provinces depending on coverage, and the cost of medications. And in general, that procedure, if we were to do IUI, only has about a 15% to 20% chance per month of doing that. And so we often do tell patients that it's something that needs to be tried multiple times. So you can imagine those costs can start to increase. Even with egg freezing, we usually advise people that it is a good idea to freeze between about 15 to 20 eggs to have a reasonable chance of pregnancy in the future. And often that actually may take more than one cycle in order to have that number of eggs. And so those costs, again, may actually be doubled because it may require 2 cycles to have an appropriate number of eggs for a good chance of pregnancy in the future. So another common scenario that we see, so I have Marina and Susan. So they're a same-sex couple who've been trying to conceive on their own. They actually had a known donor that they were using, and they were trying some home inseminations for about 6 or 7 months. They haven't been successful, so now they're coming to a fertility clinic to see what their options are at the fertility clinic. They're interested in moving to IVF because they really feel like they've already been trying inseminations on their own for quite a while. And so an IVF cycle, again, across the provinces will be different. If they're in a province where there's no funding for IVF, really it's about $10,000 to $15,000 for the IVF cycle. And the medications, again, $4,500 to $6,000. And then donor sperm in this situation. And depending on their age, that chance of being successful with an IVF cycle can be anywhere from 30% to maybe to 50, 60%, very much dependent on the age, particularly of the person who's going to be using their eggs. And in many cases, couples may actually require more than one IVF cycle in order to be successful. The third common scenario that comes into our office, so Kate and David, they've been trying to conceive for 2 years. All their investigations are normal, and they plan to start fertility treatments. So they've counseled about their options, and they decide to try IUI first. So IUI we would often do in conjunction with fertility medications. Often we may start with lower dose medications, so that might only be about $50 a month, although there are some options in which we use that may cost up to $1,000. And then the IUI itself in Ontario would run about $500 to $600 because there's some subsidy, but in some provinces may be as much as $2,000. And usually when I offer this option, it's something that, because the chance is only about 15% per month, I tell people to think about doing it 2 or 3 times before we move on. So in this particular case, Kate and David decide to try that 3 times. They're not successful. They've already now spent a few $1,000s between the cost of the IUI and their medications, and now they're ready to move on to IVF. They're quite concerned about the cost of IVF because she's just started a new job. She's not sure about her insurance coverage. And so we outline what the costs are. If they were in Ontario, then the cost of an IVF cycle may be funded. There can be sometimes wait lists and wait times associated with funding because of the fact that it's actually a limited number of available cycles in Ontario. So that's one consideration for them. And some people actually decide not to necessarily wait for their funding. And outside of Ontario, again, some provinces will also have some additional coverage or funding for IVF. And then on top of that, their medication costs. And so she's going to want to take the drug information, the DIN numbers for all the medications, and contact her insurance company and actually see if those medications are going to be covered. In addition to the coverage, details that we tell them to look about would be including, are there limits, are there annual limits, are there lifetime limits, and definitely making sure that she's going to take advantage of the potential benefits that are there if she has them. And then the last example I'll bring up is Megan and Steve. So Steve has a family history of Huntington's disease. He was recently found to carry the gene. That information now that he knows that in his family, they're quite concerned about passing this disease on to their children. So they are actually interested in potentially doing IVF or in vitro fertilization with pre-implantation genetic testing. So that allows them to create embryos that can be tested in the lab specifically for the Huntington's gene, and they would preferentially only transfer embryos that don't have the gene to avoid passing this on to their children. And to do that, they would actually, even though they themselves actually don't have a history of infertility, the process of doing this involves first going through an IVF cycle. And in addition to the IVF cycle, the cost of doing genetic testing as well. And those costs can actually be quite substantial, usually between about $8,000 to $10,000. The technology to actually screen embryos, where you only have a few cells, is very difficult technology, and it's very specific. And every genetic test that's done on embryos is actually customized in these situations when we're testing for a disease, customized to the specific family mutation that they find. So in these cases, we often have to actually do testing on other members of the family, create a specific test for this family, and then actually be able to screen embryos in the future for them. So that's part of the reason why the costs are so significant to do this genetic testing. And then the medication costs that would be involved in the IVF process as well. If they chose not to do this process, they could decide to conceive on their own and potentially perform testing in pregnancy. But there often are different considerations for patients that make that decision. And there can be benefits to doing the testing before they conceive to try to minimize the chance of actually having a pregnancy that's affected. So just to conclude, I hope I've shared the fact that fertility treatments really help build healthy families for people across a large spectrum. So in addition to couples that actually have infertility, LGBTQ families, single people that have cancer or genetic conditions, it is really, those treatments can be essential for family building across the spectrum. And fertility treatments are expensive, and there's variable coverage across the provinces in Canada. And really, the costs related to treatments can be a significant barrier. I haven't had a chance to really address that, but in my office, I definitely see that these costs can really be a barrier to patients as far as when they're able to start treatment and whether some treatments are even accessible at all. And as I brought up, time is of the essence when we talk about fertility. So even delays of 6 months to a year, which sometimes can be the case as people try to get their funds together and financial means for these, can actually, in some cases, affect their prognosis. There's a significant range of coverage for fertility medications across benefit plans, and really helping to increase coverage could really help increase access for people who require fertility treatments for a variety of reasons to help build healthy families. Thank you so much, and I'd be happy to take questions when it gets to the end.
Thank you very much, Dr. Lui, for that excellent presentation. Before our next presentation, we have 2 more polling questions for our audience. Before we had asked the question, are fertility drugs covered? Now we're going to ask the question, are fertility procedures or treatments such as IVF covered under your benefits plan? A, yes, covered in all plans. B, yes, covered in most plans. C, yes, covered in some plans. D, no, fertility procedures or treatments are not covered in your plans. Or E, don't know. So thanks for your results. I think we have more in the D and E column, and C slightly more than our previous question. So thanks for participating on that. Polling question number 4. Does the high cost of fertility treatments surprise you? Simple. A, yes. B, no. The majority said no. So thank you for voting on that polling question. At this time, I'll pass it back to Leslie.
I would now like to introduce you to our next speaker, Yafa Sakkejha. Yafa Sakkejha is a passionate advocate of equitable and transparent health coverage for the last 20 plus years. As an investor and CEO of Beneplan, she continuously disrupts the way we look at and offer employee benefits to all Canadians. Her voice has been featured in the CBC, Huffington Post, the Globe and Mail, and all top group benefits publications. Welcome, Yafa.
Thank you so much. And I'd also love to thank the sponsors of today's webinar, Mapol, and then definitely Conceivable Dreams. I think Dr. Lui did a fantastic job queuing up the medical need. And I want to talk about the money. I also want to talk about the bias from an employer's perspective. And so you're going to have to forgive me if I'm a little bit blunt, but we've got to normalize the bias on the employer side if we're going to overcome the hurdle. The obvious large hurdle is the unspoken fact that most employers don't see a true need for covering fertility benefits. The reason why they don't see a true need is because of the bias that exists when, the typical idea is that this very valuable employee is going to leave the workforce as soon as they give birth. And I'm saying that plainly because this is what business owners are speaking about behind closed doors. This is what plan sponsors or the people that are holding the purse at the company are talking about with their friends over drinks when no one's listening. And I say that because I'm often in the room. As a business owner, I'm often listening to both male and female bias. So female owners of businesses and female CEOs are also having a lot of bias when it comes to this. And so before we even talk about the money and the premiums and how we're going to underwrite this in plan sponsors' plans, I think it's really important that we definitely take a look at what Dr. Lui presented, which is the fact that it's not just that, women are waiting longer and they're older, and so therefore they made the choice in their lifestyle not to have children. It really is not that. That's definitely a component of it. But what's more important is that we have a medical need. And so the first thing we've got to do is deal with the discriminatory language in insurance contracts, whereby they sometimes describe fertility benefits as lifestyle benefits. So that's very offensive for somebody who has a physical reason or medical reason, or because of the fact that they're in a same-sex relationship. So all of these different reasons contribute to the fact that we do have a real medical need here. And so, if there's one thing I can leave you with today is that in order to shatter this bias, we as benefits consultants have to work with underwriters and insurance companies to make sure that the cost is neutral for plan sponsors. As soon as cost comes into the equation, everything seems to fall apart. And it does because there's this concept that, if I add fertility benefits to my plan, it's just going to push my premiums up. That's the natural, easy way to just push this off your desk, strike through that idea on the agenda and just proceed as if nothing happened. It's really important for us as benefits consultants who have the power to influence those in Canada who are holding the purse. And to be clear, it's not just CFOs, it's HR, it's office managers, it's really everybody. We've got to make it seamless and frictionless for them. It's not fair to put the burden of responsibility on the plan sponsor to say, you're going to go ahead and have to find more money for this. That's really the wrong way to approach it. So what I'm going to do throughout the presentation as we walk through some of the numbers is we're also going to talk about how we can make it a frictionless experience. So how can we seamlessly add these coverages without pushing premiums up for plan sponsors? So who am I? I'm a new mom. I had a child 2 years ago. I'm 35 years old. And so I really want to come out and admit my own bias. Before I had a child, I looked at fertility coverage in benefit plans differently. So admittedly, when I was in my 20s and I was helping plan sponsors curate their benefit plans, I would often observe sometimes, claims experiences would come through. You would see fertility drugs being consumed. And let's say it would be $10,000, $15,000. And then, when the plan sponsor takes a look at that, and then they're also looking at a renewal that's, let's say, a 10% increase on their premiums. The two, depending upon the underwriter you're finding, don't correlate together. In fact, at Beneplan, we make sure that we remove fertility costs and claims from renewal experience because we know it's typically a non-recurring item, and that's not what's pushing up the cost of the plan. But without that clear explanation, the employer can't help but just assume that one is tied to the other. And so therefore, I used to see plan sponsors saying, well, times are tough, we're going to have to cut. Where can we cut? And I've seen people cut fertility coverage. So I think in terms of adding, we also want to make sure that we're not throwing the baby out with the bathwater. So it's only until I had a child myself that I realized how incredibly fragile and complex it can be financially for somebody. And then also thinking about, well, I actually have a lot of responsibility. I have, the ability to build revenue in my business. I have people that report to me. So what happens if I'm working for another company and I have to take time off and I've got to dig into my pockets to the tune of $10,000, $20,000, or maybe it's only $1,000? What does that look like? So I just want to put my bias right out there in terms of how it's changed over time, because I think it's important that we normalize these discussions and recognize the own bias that we have within ourselves. I think the other bias that we have is the fact that we have a very broad definition and our industry is not settled on how you identify the need. So I think it starts right at the top. It starts with the CRA. If you look at the list of medical expenses that an individual in Canada can deduct from their tax return, that's the same list that really drives insurance company coverages. Because primarily, the only reason why an employer hires an insurance company or a carrier to provide a benefit plan, well, one of the reasons is because it's part of that tax-free blanket. So these are medical expenses that you can provide to employees on a tax-free basis, meaning you do not need to tax them on their T4s during T4 time. But the key is that, we're still behind the curve when it comes to surrogacy or gestational carriers, where it is unclear in some cases. So for example, it's the patient who's carrying the child who would be able to deduct these from their own tax return, but then it's not the funder. So the people in Canada who are sponsoring or maybe reimbursing the surrogate for those expenses are not able to take advantage of that tax return. And so as a result, when you go and ask your insurance company, well, can you also expand the definition of fertility coverage to include things like surrogacy or gestational carriers? Oftentimes I find the answer is no, because of that CRA definition, because they're following the tax code in Canada. It's the Income Tax Act that drives what is largely covered in a benefit plan. And while we have the 90% rule, meaning, make sure that 90% of the medical expenses are on side from a tax perspective so that you don't disrupt the entire plan and make it offside, it's still nebulous. And so insurance companies are also struggling with this. But what we're doing is everybody in Canada is basically pointing the finger at each other. We keep passing the buck and saying, well, it's because of this other reason that we can't do it. But I think we all need to, at the same time, simultaneously take a stand that this is the right thing to do. Let's move on. We know it's not just a female issue. There's a lot of issues when the male cannot conceive. Sometimes you have somebody who is transgender, who is transitioning and needs to have support. Sometimes it's unknown, or there's an issue with both parties, or maybe it's a single parent, single by choice. And who needs fertility benefits? I think Dr. Lui did a great job of covering it. But I think what's really interesting about this is that, just to say it plainly, do we want to live in a world where the rich can afford to have children and the rest of us are not able to? That's really what we're deciding. I mean, there's 100 consultants on this call today. We probably collectively have $1 billion of premiums under our influence. And with the employers on the call as well, you also represent a tremendous amount of influence. And so the key is that don't do this because, well, it's a financially good ROI. Forget ROI. Do this because it's the right thing to do. Do this because the next 10 years, the next generation of Canadians will be born, or they will not be born, because of the decisions that you take after this call. Let's take a look at the next slide. When you talk about the bias in terms of an employer workplace, it's very, very shameful. And unfortunately, it's very underground. So a lot of patients who talk to our call centers will say, they're very embarrassed to tell anybody. If they can't afford it, it's very difficult for them to come to HR and say, hey, can I have an extra $10,000 on my bonus? Well, because I'm struggling with this and that. It's difficult because there's that patient privacy that you don't want to disrespect. But also it takes a huge toll in terms of the hours. So when you talk to a patient who maybe is going to the fertility clinic every day to get their blood tested or to go through treatments, Dr. Lui will tell you, it's like, you're waiting in line sometimes between 7 a.m. and 11 a.m., depending upon how busy that clinic is, depending upon whether you were late, whether another patient before you was late or not. And so how do you explain to your employer that for 5 days of a week, you might show up an hour to 2 hours late? I mean, I know we're in the pandemic, we're all working virtually, but I think a lot of that starts to put strain on the employer-employee relationship. Managers are certainly out of the loop on how to help. There's very, very little policy there. There's also a huge fear of negative impact on the career. So a lot of people are often terrified that if they move jobs, they're going to lose their ability to even have a child. And so I've noticed that there are people that are cherry picking the employers that they work for based on their experience. A huge bias I hear from business owners, male and female, is people admit, hey, if a 27-year-old female and a 27-year-old male walks into my office for the same job interview, for the same role, we still have bias against the 27-year-old female because there's this perception that, well, we're going to lose them to having a child, and it could be 2 years, it could be 5 years, they could never come back. So why am I going to invest all this time and money training this person when she's only got one ring on her finger, not two? And we know that the next step is the child. And so that is still a huge bias that we have to shatter, because a lot of people who are experiencing struggles with having a family, it's not just that 27-year-old female or the 35-year-old female or the 45-year-old female. It's people who are single by choice. It's same-sex couples. It's males that don't have proper sperm that are able to, conceive. And so it's really, we have to break that bias there. We know that the treatment can be quite expensive. I think we touched on that in the previous presentation. But I think what's interesting is that it's still a spectrum. So not everybody needs to spend $50,000 on growing their family. There are some people that spend a few $100s or maybe $1,000 or $2,000. And so, whatever we are able to seamlessly add into benefit plans can help. So we're not asking you to take out your checkbook and just write a blank check. We're asking you to throw a bone to people. Throw people a bone where you can afford it. And we'll talk about the underwriting in a second. Why don't insurers cover this? I think, again, we have the pass the buck type syndrome. So the concept with insurers is, well, it's the plan sponsor who dictates to us what their plan design is. When we pick up a new benefit plan, we're just matching the previous plan without deviations. And so, don't look at us. As benefits consultants, we often think, well, we have no say in this. The client wants this plan design, we're going to add it. Except if you've actually ever meditated on how this comes to be, find the employer who's just added a benefit plan. Find that person and ask them, why are you adding a benefit plan? They're going to say, well, we lived for 5 years as a business when we couldn't afford it. Suddenly I had to hire a CTO, and they looked at the fact that we don't have a plan, and they said, I'm not going to work with you unless you have a benefit plan. So that's why I added a plan. Full stop. They don't go necessarily into details about which DINs are covered or which formulary. They're honestly too busy. And who can blame them? It's not fair to put that kind of pressure on an employer. We're asking employers to basically act as the Canadian government. The Canadian government are the ones who say, this is what we can afford, and this is what we have to unfortunately say no to. And so to ask a business owner or a CFO who's trying to grow a business to make that kind of decision is unfair. So it's not fair to say to employers, well, you didn't tell us to have fertility coverage. It's really difficult. And then, once it becomes a default on or default off, then that's when hundreds and hundreds of contracts get passed through. Now, we have to address the systems issue, because I think a lot of insurers often see, we have a large grand idea to change benefit plans, and they might pause because of the system constraints it might add. A lot of people, including myself, have had pain in trying to migrate systems from legacy to new ones. And part of the reason why coverage doesn't just magically change from year to year is because there is a cost in the system to make those changes. So I think we all have to be patient with our insurers as well. We have to be patient with our underwriters. I think we're all trying to work towards this together, but I think we have to stop thinking that it's one party or it's another party who makes a decision. It's not. It's really all of us together. And really, it's a product that needs to be underwritten like insurance. It should never be priced the way vision or massage is priced, whereby it's an experience rated benefit. If you're seeing that happening, you really have to have a hard conversation with your underwriters. It should always be removed. And I don't want to hear that it's about cost, because, I'm looking at my 2020 blocks pandemic numbers, and, the surpluses are just wild this year. So I don't want to hear anything about, well, we don't have extra money, okay? I'm just going to call it like it is. So the benefits are rising in demand in the workforce. Millennials are definitely aware of egg freezing. Women represent an increasingly high percentage of the Canadian workforce, although we know it's not just women that are affected by this. And it really is a helpful way to help people work through the stressors in their life. So a stress can definitely include how you grow your family. And I think what we're seeing right now in employers is that we, in the early 2000s, late 2000s, around the Great Recession, we noticed employers were on a cost cutting mode. But more and more advisors I talk to now are saying employers are switching now towards, they're in a war for talent. So the essential businesses that have allowed to continue to work are working double and triple overtime. Their employees are under strain. They can't hire a few people fast enough. And so this can be an incredibly powerful employment recruitment tool. We also see that more leaders are supporting the fertility industry. So we have a number of Canadian leaders like Alyssa Atkins or Michelle Romanow in Canada that are supporting this trend. We also have business owners in the United States. I think what's interesting is Legacy, led by Khaled Kitali. That's a company that's focusing on the male fertility side of things. And so I think what's amazing is that we're shattering these societal norms together. And then if nothing else, just notice the fact that you're sitting in front of more females in the purchasing process. I think maybe 30, 40 years ago, if you looked at the typical prospecting meeting or the renewal meeting, you might have a male president, a male CFO, and then a female payroll administrator, while today it's possible that you have a different mix of that. And I find as women enter the C-suite, again, we know it's not an issue that only women face, but I think traditionally this is going to help in the influencing of the purchasing process. When I look at our own web statistics, like, who are the people visiting Beneplan, it does skew highly female. And I think that's because not just HR, but more women are entering more influential positions in the workplace. So 3% is really a magic number. Obviously, 3% is different for different carriers. So I'm just talking about our own block of business. We asked both cooperators and Green Shield Canada for some statistics on the block. And we found that definitely for $2,500 of coverage in the benefit plan, and when I say coverage, I mean both drugs and treatments, there's zero change to premiums. So that's something where overnight, there should be no excuse why at every renewal, at every plan amendment, at every implementation, you're adding at minimum $2,500 of coverage for zero change in premiums. Between $5,000 and $10,000 of lifetime coverage, that's when you're looking at 3% of premiums. And I know that professionals on this call, you can find 3% of premiums. I know, because we find 3% of premiums all the time. Some of the seamless ways that you can do that are implementing a managed drug formulary, going to mandatory generic. Those two things are an instant 3%. Sorry, when I say premiums, I should clarify, I mean health premiums. So the healthcare rate, you would have to separate pooling. So healthcare minus the pooling charge stop loss. But we all know a managed drug formulary, or the fact that in Canada we're still paying for 75% of our drugs, are still brand name drugs in the private sector. That's awful. It really should be higher than that. The other piece that you could look at is you could look at changing your funding structure. So anybody who is currently fully insured, if you're comfortable with the risk of ASO, I think actually historically today, February 18th, 2021, is probably the worst day on record to go ASO, because the economy is just about to open back up. And all those surpluses from 2020 are going to get eaten up by the way people are going to go back to claiming paramedicals, going back to dentistry when we feel more comfortable and secure in in-person environments. But that said, I think you can talk to us about what are some other different structures. So we have a hybrid, fully insured ASO approach, whereby you're able to recover on average 6 to 10% of the health and dental premium as a refund or dividend to the company. And so there you go, you've just paid for that right away. So at this point, I'd love to pause. And again, thank you to our hosts. Thank you to Mapol, and thank you to Conceivable Dreams. Thank you, Johnny, and Dr. Lui as well. We really appreciate your time.
Thank you very much, Yafa. Great presentation. We have already received a few questions that we'll save for the end. But before we move on, we have 2 more polling questions. Polling question number 5 is up. After hearing this webinar, would you be willing to reevaluate and increase your client's benefits plan coverage in regards to fertility benefits? Okay, so we have a tie between A and C, which is yes or maybe. That's encouraging. Let's see question number 6. Question 6 is, what action would you recommend after hearing this webinar? A. Review plan contracts to ensure fertility benefits are not excluded. B. Advocate for mass contract amendments to allow for the coverage of fertility benefits. C. Speak with plan sponsors on the value of covering fertility benefits on their plans. D. All of the above. Or E. So the majority here have selected C or D. Speak with plan sponsors on the value of covering fertility benefits on their plans, or all of the above. So thanks very much for that response to that polling question. So at this time, we would like to begin the question and answer period. So here's the first question we have for Dr. Liu. What is the ideal number of IVF cycles that should be done in this country for actual infertility treatment alone?
I don't know if I can give a number to that answer. I mean, I think that there are different indications for doing IVF. There's other treatments, as I mentioned as well. What I find interesting to answer that question is that we've got interesting data now looking at in Ontario with funding of IVF and the timelines of what that will be as far as when people can access IVF treatments. And actually, we've got some historical data as well, because there also used to be a previous funding program in Ontario. And I think it's interesting when we look at that compared to other provinces where they don't have the same amount of funding. One of the things about infertility is that there is very much a patient and physician partnership as far as what patients choose as far as fertility options. And so there's a number of times where there are potentially a number of different options that are available for people. And every couple, I think, is going to make a different decision as to what the best next step that they want to have. And I think that decision is based on a number of things. It's based on their patient factors. It's based on their values. It's often, in many cases, based on what the success of those treatments are. And then I think financial piece, which is very different in this area of medicine than other areas of medicine, as to financial implications of that decision as well. So I think those are all pieces that help drive when people choose to do IVF and when they choose that as an option. And I do think it's a unique area compared to other areas in medicine where often that financial piece in the decision isn't necessarily as significant.
Great. Thanks so much. We'll get to the financial piece shortly. Here's a question for Yafa. Why $5,000 for lifetime coverage? It feels kind of insufficient with regards to typical fertility spend. Any comments, Yafa?
You're right. It is insufficient. I mean, it really should be 15,000 or more. But what I was trying to, listen, you can pick whatever you want. I think what I was trying to say is, in order to make it a frictionless experience, the way that you can do so across your entire block is to say, hey, we've got this new strategy in place for no new premiums. You're able to add $2,500 to $5,000. Overnight, because it's frictionless, you're probably going to pick up about 90% of your base to say, yeah, go ahead and make the amendment. I think as soon as you start to say, well, it's going to cost anything more than 0.5%, and definitely on an off renewal cycle, that's when you're going to get pushback from the employer, because we know we can't just unilaterally add costs to an employer without their consent. Unless, of course, it's coming from the insurance companies. If you want to go the insurance company route, you can. I just do think it's going to take years, and that's fine. We can do that all in parallel. I do think this is a marathon and not a sprint across the board.
That's great. Thank you. Here's a question. I think CRA tax code is very important, as you say. So the question is, how can plan sponsors help with fertility costs for heteronormative couples when benefits are not included in the CRA tax code?
That's a great question. I'm just going to speak from the TPA perspective. I think all TPAs in Canada should look at, or TPPs, so third-party payers who are flexible and nimble, should be able to add some sort of claim policy whereby if the employer is happy to pay the cost, you can do so. I say that because I think it's dangerous for employers to self-adjudicate. That's when you really touched into the area of potential health discrimination or potential family status discrimination. So effectively, if you're not able to outsource it to a third party, that's when, if it's still a taxable benefit to the employee, that's when employers typically say, well, if it's taxable benefit anyways, I'll just give people extra cash. So I do think it needs to come through a third party. I think our industry is not there yet, but it's a great question. And I think I'll bring that to our industry peer group.
No, that's great. And one question here is, Do you suggest adding coverage through a taxable spending account?
Yeah, you absolutely can. That's when you would do it unilaterally. The only key there is that adding a taxable spending account, you've got to do it to all classes or on a class basis. That's definitely going to push up significant costs for the employer because, as you know, Emma, a taxable spending account, you can cover your yoga mat or your running shoes for things like that. And definitely people who are not trying to grow their family are going to definitely be claiming for their running shoes. So I like the insurance approach because it doesn't push premiums up overnight if it's underwritten as an insurance product.
Wonderful, thank you. Here's a question. Another question is, can you talk more about surrogacy benefits again, on why it's not covered and what options do plan sponsors have to provide coverage?
So I'm just going to speak from the CRA's perspective. So if you actually read the Canada.ca Revenue Agency definition of medical expenses, in the list of medical expenses, you can deduct from your personal income tax and therefore extrapolate that to a benefit plan. Procedures towards fertility related procedures paid to a medical practitioner, public or licensed private hospital. However, they say generally amounts paid for a surrogate mother are not eligible. And the reason for that is they're saying, well, the mother or the patient themselves who is getting pregnant, they can deduct those expenses from their taxes, but the couple, so to speak, that's sponsoring that mother is not able to from a tax perspective. So I don't know if people are, under the table working that out separately, but, I think insurance companies are always going to point to that to say, well, that's why we can't do it. Now, that said, I'm not an insurance company per se, so I think it definitely is a good thing to spark a discussion with your carrier partners.
That's great. The clarifying question was, in some of the slides, we referred to medication costs at around 4,500 to 6,000 or even up to 7,000. It could be quite variable. Just to clarify, is that per cycle?
Yeah, so those would be pretty typical costs for an IVF cycle, per cycle.
Wonderful, thank you. I think we have time for one more question, and this question is around faith-based bias. Are there faith-based bias as well that may affect access?
I think from the perspective of the treatment choices and options that patients choose to, there definitely are conversations that we have that affect the choices that people make for which options are right for them. And I think that plays into the complicated decision making that patients have when they're deciding what the appropriate fertility options are for them. I think, as I alluded to, the decisions that people make, there's many factors that go into it. And I think that the values and expectations and in some cases maybe faith of that couple might be part of that decision making. And we've definitely had to have conversations for people, I would say specifically around things like IVF or around freezing embryos and what the potential disposition of are for those embryos very much are part of the conversation and the factors that people use to make those decisions, in addition to the success rates and as I mentioned, the financial pieces for them as well that really all are significant when we have conversations with patients about what their options are and what they might choose to do, and the financial piece I would say is very significant piece, but definitely we have conversations with patients about their values and their faith in some situations that drives the decisions that they make.
Great, Dr. Lui. And I think maybe Yafa, in terms of when you talk about the biases in plan design, is there faith-based biases?
Oh, absolutely. I mean, every plan sponsor has a different idea. And so that's why I think it's not fair to ask the plan sponsor to make the decision. We've got to, as an industry, say, this is the path that we're taking together. Please join us.
That's wonderful. We are at the top of the hour, and I see a number of questions that are still coming through, but we really appreciate it. We'll try to address them after the webinar. We want to be respectful of everyone's time. So thank you very much for the lively discussion. I will pass it over to Leslie to make some concluding remarks. Thanks.
If we were not able to respond to one of your questions, or if you have any additional inquiries, please email us directly. Our email address is on the screen, info@mapol.ca. We would like to thank our guest presenters, Dr. Kimberly Lui and Yafa Sakkejha. We want to acknowledge sponsorship of today's webinar by Conceivable Dreams. To learn more about the Fertility Benefits Matter campaign and research, please visit fertilitybenefits.ca. Today's webinar is part of the continuing series offered by Mapol. Please save the date for our next webinar on Wednesday, March 31st. Email invitations will be sent in the coming days. Be sure to look out for it soon. If you're not currently on our email invitation list, you can submit your contact information using the link on the Mapol webinar page. Also, for the latest news and updates on upcoming webinars, please be sure to follow us on LinkedIn. Thank you again, and goodbye for now.